Okay, every student, and my name is Jen Tai Timothy Q, and you can call me JT. I'm a GIN doctor. I also earned my PhD from the United States for microbiology and immunology. Can you hear clear?
Yes, Prof.
Okay, great. Today our focus is the reproductive system. We will talk about a little bit the male and the female reproduction system. Then we will mention the mechanism of hypothalamus, pituitary, and the ovary axis. Then we'll mention about the menstruation cycle in the woman. Also, we will talk about the ova and the testes, the gametogenesis. So, and the final part, we'll talk about pregnancy, childbirth, and the breastfeeding, and some new technology in the reproduction system for the infertility patient. I will talk about a little bit contraception because I have so many busy work, so I put many slides in this time. I did not put every slide in together, but when you look at the video, it will be fine. So be ready, and then let's start it. So what is the reproductive system? The system is include the primary and the secondary sex organ and the sex gland. This is for our next generation through the sexual and the germ cell fertilization and for the reproduction. You know, from the brain, there's a pituitary gland, and the female have a uterus, ovary, and the breast. And for the male, we have testes, scrotum, penis. We will go this in detail later. For the female, we know this is the uterus. And the uterus, there's 3 parts. Is the cervix, then there's the body, and then the fundus. Uterus is the location for the baby. And when we do the surgery, we will dissect the anatomy of the uterus. They have 5 ligaments to hold the uterus in the normal position. And 70% of the female is an inverted uterus, and they have a different kind of uterus position. This part is the vagina, and you can see they have a different position. But majority of the patient, they will be fine, still can get a baby. And the uterus have from this inner layer is the endometrium. Then the middle layer is the myometrium. The outer layer is the peritoneum. So these different parts have different disease, like endometrium, maybe have a endometrium hyperplasia, have a endometrium polyp. And the mid layer, the myometrium, maybe have a uterine myoma or adenomyosis. This is kind of endometriosis. The outer layer is the serosa. The peritoneal layer. So some people have adhesion with the intestine. So the uterus have a baby over here. This is the normal vertex position of the fetus, and they have a placenta provide the blood for the baby. And I will talk about the fallopian tube. Fallopian tube. They connect between the uterus and the ovary. And the ovary, they produce the ova, the egg, the ova. Then they migrate through the fimbrial end to the uterus. And almost 90% of the fertilization is happened in the fallopian tube. So this is a female reproductive system. The ovary, you can see the section of the fallopian tube. Here, there's a very complex structure. And the middle part is the ampulla or isthmus. Isthmus is the thinnest area. Sometimes, once this have inflammation, tube will be blocked. Then the ova have no chance to mate with the sperm. You can see the sperm, and once they get fertilized, they will migrate into the endometrium. They got the implantation. This is become an embryo. And you look at the anatomy here. This is uterus, and this is ovary. We have two ovary, left side and the right side. This is a very magic organ. They produce hormone and they produce ova. And you can see the ovary once we could do the section. The ovary, they have a primordial follicle, then become a primary follicle. Then they growth become a secondary follicle. Then they have a follicle, have a mature ova. Then they rupture. Rupture we call ovulation. Then the ovulation, the ova will go to the fallopian tube. Then the ruptured follicle will become to a corpus luteum. This corpus luteum will produce the hormone progesterone. The progesterone will maintain the endometrium stability. And then they will go on to atrophy, become a corpus albicans. And the ovary is very interesting and very magic organ. Sometimes you can see not only the ova, they produce hormone. Sometimes they go wrong, they will become an ovarian cancer. And ovarian cancer is very difficult cancer to treat because majority, almost 70% of the ovarian cancer, once found is advanced stage 3 or stage 4. And there's a treatment outcome is not good. So the reproductive system, we talk about the vagina. Vagina is a tube organ, and they from labia major and labia minor, and the end of the vagina is the cervix, and the cervix, once they got the HPV infection, and if we do not have a good pre-cancer screening, they become a cervical cancer. Then we go out of this vulva. You can see this is the vulva area. Once you have a pubic hair, there is a labia major. There is a small skin fold, no pubic, no hair. Then this is labia minor. And in the middle, there's the urethra opening. And this is the vagina and the hymen ring. And the end is here is the anus. So we know there's the 3 orifices. One is the urethra opening. One is the vagina opening. One is the GI anus opening. So the vagina is easy to get contaminated and easy to get the infection. The anus maybe have some bacteria like the E. coli. So they sometimes have vagina discharge, vaginitis, or pelvic inflammation disease. So the vulva, this is when you deliver a baby. The baby, the head is big, so the doctor will cut a little bit of the vulva to open up. Then the baby's head can go out smoothly. Procedure we call episiotomy. episiotomy. Then we talk about the female reproductive system in the breast. We know the breast to have a milk to feed our baby. Or this breast anatomy, they have a different gland. They have adipose tissue, and this is the nipple for the baby to suck the milk. So they have, but they produce the milk, but it's controlled by the hormone called prolactin. So after the childbirth, our pituitary gland will stimulate the breast lobular gland with the hormone with prolactin. Then the breast start to produce milk. Then, the breast, we have breast cancer. Breast cancer is happen in this ductal area. Right now, we have a gene test like the BRCA1. Then once you have a gene defect, it's easy to get a high chance to get a breast cancer. We can do the screening by mammography. Then we will talk about the menstruation cycle later. There's in the second slide. The menstruation is the endometrium layer here. The endometrium, once we do not get fertilized, then the endometrium will shading. Then the shading, then the next month we have new endometrium. When the ova and the sperm got fertilized, the fertilized egg, they will implant in the endometrium. So the endometrium, we call the receptibility for the implantation. So the most important thing, the female reproductive system is the pregnancy. This ova cell, the sperm come into here, and they get fertilized. Once they fertilize, they migrate from the tube to the uterus and implant here. Okay, so later will show they have a chromosome. The cell, fertilized cell, have 46 chromosomes. Then the single cell will divide, then called the blastocyst here, or the blastomeal. So they fertilize over here. Then there's a zygote, blastomeal, medulla. Then the embryo will get implanted in the endometrium. Right now, you can see the pregnancy, the early pregnancy. They have a placenta, and the placenta will have a chorial, meaning villi, and the yolk sac. They provide the initial nutrition for the fetus. Once the blood supply of the placenta bigger and bigger, they get the nutrition from the mother, or from the blood of the mother. This will happen during the first trimester. During the final third trimester, this is called delivery the baby, or this baby come out the head. This is umbilical cord. They provide the nutrition, the blood from the uterus to the fetus. Once the baby cry, and we cut umbilical cord. So this is vaginal delivery. Sometimes the mother have a difficulty to deliver a baby. We can do the cesarean section. This cesarean section is the incision in the abdomen from here, and we can move the baby from the abdomen. This is a kind of surgery. The final result is we want to get a healthy baby. Then we have a new generation. We will the baby will be evaluated by the so-called APA score from the 1 to 10. 10 is the perfect. The color, the heartbeat is okay. good reflex, good muscle tone, good breathing. Then there's a 100% is 10 score. So the pregnancy have some complication, like placenta previa. Placenta previa is the placenta located between the fetus head and the cervix. So once to come out, the placenta will have a laceration. During the laceration, they have a massive bleeding, and the baby will have a so-called anemia, and the lack of the blood supply. So it's a very dangerous condition. So this spontaneous abortion or miscarriage happen. So the prenatal diagnosis to find the placenta previa is very important. One placenta previa, we will do the cesarean section. We cut the abdominal wall and the uterus here, and then remove the baby from the uterus, from the abdominal. Not go into the cervix. Otherwise, the mother will have a dangerous complication. Then we will talk a little bit male because I'm the GI doctor. The male, I'm not my expertise, but we can see there's some common knowledge is the male have a penis, and they have epididymis, and they have some so-called spermatic core. The sperm produced here, then they will move from the penis, have a ejaculation. And we know the male, the gland will have a so-called foreskin here. Once like Jewish people, they circumcise the penis. Then you can see they remove the foreskin. So the gland is open. This is penis. Then the penis, the function for the intercourse. They have put into the vagina, then eject the sperm into the vagina and close to the cervix. Then we look at the male, the testes. Here is the testes. They have so many tubules, and the sperm produced inside the testes. Then they will storage in the epididymis. The mature sperm stored in the epididymis, and this is very long, of 13 to 20 feet tall. And so average is about 3 to 5 male of 3 to 5 milliliter of cc of the sperm. The sperm is very abundant, average about 2,000 million of the sperm, like this. And the sperm, like a very powerful car. There's a head, the DNA inside here, and the 90% of the sperm have a mitochondria, and then they have a tail, or they have a moving around, and put a sperm can migrate and to search the ova. So the sperm, the head of the sperm have an enzyme. The enzyme can penetrate the ova. So there's a very magic the miracle in our human body. And the tail have a flagellum. They provide the motility. And this is the sperm penetrate the ova electron microscope picture. So the male, you can see these very important organs, the vast difference. The sperm produced, but they migrate very long distance. This is the prostate, and once we want to do the contraception, and we can have a ligation or break the vast difference. Then the sperm will store here, never come out, and the sperm will die, and our human body can absorb. And the sperm, the semivesicle will produce alkaline fluid. Alkaline fluid can neutralize the acidic condition in the vagina. So they can protect the sperm, avoid the acidity of the urethra and the vagina. Then we will, male have a so-called prostate. Prostate is here. The dark blue color is the prostate. The male sometimes have a benign hyperplasia of prostate, BPH. Then they have dysuria, not easy to urinate. And the prostate, once they become a prostate cancer, or it happens in the older people, 70 or 80, it's easy to get a prostate cancer. Prostate cancer, once you do the surgery, sometimes that you will influence the nerve, then the penis, the erection will have a problem. Once you do the surgery, then the sperm destroyed. So the prostate cancer surgery is a very delicate and very difficult surgery. Okay, so this is my first part of the anatomy and the physiology. Do you have any question right now?
Yes, class, please, if you have question for Prof. JT, Prof. JT, right, Prof? Yes. Yes, question about the anatomy, I think. Yes, Haris? Haris, question?
Not yet, ma'am.
Okay, if no question, I go ahead and
Okay.
find out we can final discussion.
Okay, Prof.
And right now we want to switch here to the pituitary. I borrowed the slide from UAB, Dr. Janet McLaren. I want to appreciate him because I borrowed his slide. During the slide, we'll review the physiology of the hypothalamus, pituitary, and the ovarian, so-called HPO axis. Once you know the interaction between these three organs, we can know the menstruation and the hormone change. So we look at the physiology of the HPO. So this is very top secret. I will disclose the top secret for you. HPO is from the hypothalamus in the brain. Then there's a pituitary gland. The hypothalamus will release so-called GnRH. This is a small peptide hormone. They stimulate the FSH and the LH. FSH, the luteal hormone, luteal phase, luteal hormone, and it is follicular stimulation hormone. These two hormones produced from pituitary. Then these two hormones will control the ovary. Ovary in the beginning, they produce androgen and in the beginning produce the estradiol, so-called E2, estradiol. And the second half of the menstruation cycle, the progesterone and the androgen will goes up. Then they control the uterus, the endometrium. So this is a very wonderful, very synchronized, just like orchestra. You have a coordinated action. So FSH and LH, they produce from anterior pituitary gland. These two hormones is a glycosylated polypeptide. They have a alpha and beta subunit. The alpha subunit is identical to thyroid PSH and the human gonadotropin hormone HCG is so these gonadotropin hormone stored in the cell, and the GnRH release is positive. They have a very good neuroendocrine feedback. If the GnRH is the slower frequency, positive release, they will favor FSH release. If you have a faster frequency release, then they favor LH release. You can see here, the ovary, they majority is to make an ova. The process we call the follicular genesis. The ovary is very broad abundant. They have an artery and venous, primordial
Prof, I think you haven't moved the slide. We still see the previous slide. Yes.
Do you see the ovary right now?
No, not yet, Prof.
Okay. I see there. This will be late. Then move up, move down.
Okay, maybe you should close the slide first, maybe, Prof. And then try to open again. Okay. Close this, yes.
So do you see the slide?
Not yet, Prof. Still anatomy and physiology, the end, Prof.
Okay, here. Can you see the slide?
Yes, Prof.
Okay. So there's I found the slide from the UAB, University of Alabama at Bloomington. And do you see the slide?
Yes, Prof.
Okay. So here, you see this before? Do you see this very important slide here?
Yes.
Okay. So this is a hypothalamus. Hypothalamus will in our brain, they produce the small peptide GnRH. They use a positive, low frequency or high frequency. Then this frequency will control the release of the FSH or LH from anterior pituitary gland. And these two hormones will control our ovary. In the beginning, if you have a high FSH gland, they will produce estradiol, high estradiol in the beginning of our menstruation cycle. Then almost 2 weeks later, LH will be higher. Then the ovary will produce progesterone. Then these two hormones control our uterus, the endometrium. The endometrium, I will show you later, they have a menstruation. So the anterior pituitary gland, this is a glycosylated peptide. And they have alpha and beta subunit. Once you release, there's a pastile to control the feedback. And this is very important slide. Our ovary is from primordial follicle. This is so-called our reserve of our follicle. We can check the AMH level from our blood. If AMH is over 4, then your primordial follicle is very abundant. You are healthy. The mature over by yourself. If your endometrial follicle is limited, the AMH level from your blood less than 4, sometimes less than 2, then it's not easy to get a baby by yourself. You need to have a so-called infertility workup by ART technique to help you to get a baby. So if you are healthy, the primordial follicle will get bigger and bigger. This is controlled by our hormone. And the final product is the ovulation. Ovulation, this is the mature ova. Then once ovulate, this follicle become an early corpus luteum. They start to produce the progesterone hormone. This is a mature corpus luteum. This corpus luteum is very easy to breathe in. Sometimes we have a sexual activity, then the very aggressive sexual activity, then the corpus luteum will rupture. Some patients will have internal bleeding, go to our emergency room for their abdominal pain, and then we check the blood. They have some anemia. They have a hypovolemic shock. We need to do the surgery to stop the bleeding from the mature corpus luteum. So-called corpus luteum rupture. This is a very dangerous disease, life-threatening. This is a very important slide, so-called top secret. Here, we know this is the top secret. Sorry about it, I'm taking a phone call. Wait. 对。哦，太好了，那这样子我真好，那就良心了。好，没关系，你就尽量消。我现在在帮学生上课，你消完之后可以休息，再回去。好 ，OK， 可以 ，OK， 好，拜。Okay, sorry about that. There's a phone call from hospital. This is so-called top secret. We will decode the top secret by this slide. So this slide, the bottom is the ovulation day. From the day 0 to 28 days, this is so-called cycle. Then the 28th day, we have a menstruation. And here, this is uterus endometrium. Endometrium from the endometrium menstruation, so they're very thick, then disappear and start from the basic level around 5 millimeters. Then they will go up day by day up to 2 centimeters. If there is no baby implant, no embryo implant, and they will lose the progesterone support, they will shedding again. There's another menstruation. This is the uterine cycle. And you can see here, this panel is the ovulation hormone. In the beginning, we have a high estradiol produced day by day. And then come to here, estradiol will suddenly decrease because this is so-called ovulation. Then you can see the purple line is the progesterone. in the beginning, they is very flat, low level. Once they overrate, then the corpus luteum happen. The corpus luteum become mature, they produce abundance of the progesterone. The progesterone can maintain the thickness of the endometrium. This is a way of implantation. If they wait, still no embryo implant, the progesterone will decrease, then decrease to a certain level, then the menstruation come out. Then we can see the anterior pituitary gland hormone, so-called FSH and the LH. In the beginning, in the first half, in color, the FSH is higher. They can stimulate the estradiol. So FSH help the follicular formation. The follicle will be bigger and bigger. You can see this ovary, the small follicle, and growing follicle is by the green color FSH. Then suddenly we have a so-called LH. They have a surge in the peak here. This is happening in the ovulation. Then after ovulation, they have a corpus luteum. The corpus luteum, the yellow corpus luteum produce the progesterone, the purple line. So this is controlled by pituitary gland, this hormone. So LH surge induce the ovulation. They surge, they come down, then maintain a certain level. When we look at the body temperature, in the morning, we look at the body temperature. They around a stable condition. During the ovulation day, LH surge, the temperature will go up about 0.8 or 1 degree. 1 degree. So you will. This is a good time for mating, for intercourse. You have a high chance to get fertilized. Then the body temperature will maintain a little bit. Once the progesterone go down, the body temperature will go down back to the normal baseline. They can see the ova. They produce the ovulation, then the follicle become produce progesterone. So this is a very key, very important slide for our female hormone and organ, the change during the menstruation cycle, during the 28th day, what happened? Okay. We can use the ultrasound exam to check the ovary and the uterus development. We use the ultrasound, we can see the follicle, how big is the follicle. In the early stage is a small follicle, and the endometrium lining is very thin, about 5 millimeters. So the menstruation cycle provide the insight, the function of HPO acids. The cycle occur around 28 to 35 days. So the regular cycle means you have ovulation, then the estradiol produced by the growing follicle. And sometimes we have oligomenorrhea, some amenorrhea. Amenorrhea is the no menstruation, depend on the cause without the hypoestrogenic status. So we can check the blood to check the FSH and HE2 level to see what's going on during the disease. This is a rare disease, hypoprolactinemia. This is not our topic here today. So you guys, do you know the HPO acids from hypothalamus between ovary and the uterus. This is a simple paradigm and become a very complicated but very important physiology of female menstruation. Any question? Okay, if no question, let's go further.
No question yet, I think, Prof.
Okay.
Okay, Prof.
So do you see the new gametogenesis? Okay, we have a new slide here. Gametogenesis. This is go to the basic genetic knowledge. We know we have a 2N, 4N, and oocyte maturation. The mature oocyte is 1N, single copy. Then this is a mature oocyte. Then we have a sperm. Sperm is 1N. Size, they go back to 2N. So half of the genetic material from mother. The second half genetic material from father. Then we can go back to the gametogenesis. They have a so-called meiosis. So they have spermogonium, spermatogonium is a master cell. Then they have a primary spermatocyte is 4N, double. Primary oocyte is double, 4N. Then during the meiosis, they lost the first polar body. They lost the second polar body. So they become 2N and 1N. And this is a similar condition in the sperm. Secondary spermatocyte is 2N. Spermatid is 1N. Once you got a tail, is a sperm. They have a migration and a fertility or motility. Okay, so sometimes the test will question you how many N in the secondary oocyte. Is easy to remember. The secondary is 2, so 2N, right? And the mature is half, so it's 1N. Okay, so this is gametogenesis, the formation of gamete, and the gamete is developed in the gonad, the sex cell. In the male, the spermatogenesis is the formation of sperm. In female is the oogenesis, formation of the ova. You can see here, there's a 1N, 2N, meiosis 1, meiosis 2, quite similar here, but you need to remember what's going on. And when we do the ART, artificial reproductive technology, during the microscope, we can see the polar body. Also, we can see what's the status of the oocyte. I will show you later. This we can see there is a sperm. There's a testes. When you look at the testes here, so many sperm cell formulation here. This is a diploid spermatogonium. This is the master cell. Master. They produce, then they have ability to have a mitotic division. There's a primordial germ cell. Then the final product is the tail, the sperm. There's a haploid. Sometimes the germ cell will have a disease we call germ cell tumor. Germ cell tumor is very happen in the young age. Female and the male, there is a cancer state, is a cancer, germ cell tumor. And for this cell is the cancer is very sensitive to the chemotherapy. Sometimes we have stage 4 stem cell tumor cancer. We can preserve the ovary and the uterus. We do the chemotherapy, then the cancer cell will goes away, and the normal cell will left, and they can produce the normal ova and the sperm, so they can preserve the fertility. This is the so-called germ cell tumor, GTN. Okay, so there's a stage in the spermatogenesis. Okay, this meiosis 1 and meiosis 2, and the spermatozoa have this tail, and then there's a spermatid. This sometimes so-called terminology. Okay, the final product is sperm. I showed you before. The sperm, the head have an enzyme. They can penetrate the ova. The oogenesis, you can see from the follicle. Inside the follicle, the cell, the diploid, and the primary oocyte. Then the otid is a haploid. Mature ova is a haploid. They go through the mitotic division 1 and mitotic division 2. This so-called oogenesis. Okay. Polar body is a small condensed DNA here. Okay, so we put together sperm and ova. We can make a comparison. Okay. When you look at the human is 49 chromosome, and the polar body have 23 chromosome. Second polar body, there's a mature one ova is 23 chromosome inside. Okay. This is so-called term gamete, egg or sperm, gametogenesis, oogenesis, spermatogenesis, spermiogenesis. This is the differentiation of sperm morphology, the follicle, the ovulation, the polar body, the zygote. Zygote is the fertilized egg. There is 2 N. Okay. So this is our then I will switch to infertility and so-called ART. ART, let me find ART here.
Yes, Prof.
You know,
One
yes.
student, Prof.
Yes, you can.
Yes, one student has already raised hand to ask you question about this menorrhea in the chat, Prof.
How you text?
Yes.
Okay, let me find out. Okay, here I see. I have one question. In one ejaculation, how many sperm come out and the fertilized egg? The sperm will be have around in Chinese to 2,000 million. 2,000 million of the sperm in one ejaculation. And one fertilized only 1 egg. The female produce mature 1 egg once per month. If the female produce 2 eggs, you will have a so-called the twin, the two baby. Sometimes once you have one sperm, 1 egg, then they divide, they separate. Then we so-called this the twin, but the twin is similar, like a boy and a boy. So that depend on if you have 2 eggs, maybe you have one is a brother, the other one is girl, is a sister. The twin baby, different combination. So one ejaculation, so many sperm, but so many sperm only pick one, because once the sperm penetrate the ova, then the ova will the cell membrane will have changed. They prevent the second sperm to penetrate. It's very interesting. But once you have 3N, some people will have the 2 sperm get into the ova in the same time. Then the baby will have a so-called aneuploidy. They have 2N, they have 3N or 4N. Then the baby will not going well. There will abortion. So sometimes the majority of the early pregnancy, the abortion, is due to the gene, the copy number. Okay, this is the first question. Then let me try to answer. Okay, here is Vita. I have asked about dysmenorrhea. Right. Use doctor says normal, say to take painkiller to release the pain. It's okay. I take every month. Thank you. Okay. Yeah, this is a very frequent question. Dysmenorrhea is painful menstruation. You know why? Because the uterus and the cervix is very small, and you have a shedding of your endometrium. It almost have 80 male per month. So sometimes the menstruation goes not smoothly. You will have a pain. But being a doctor, we will check during the pain, do you have any lesion like myoma or adenomyosis or endometriosis? If we cannot find any organic lesion, we call this is a primary dysmenorrhea, painful menstruation. Then we will suggest you take a painkiller. Once you got pregnancy, have a baby, then this is primary dysmenorrhea will go away, because you will after the delivery, your cervix is open, your vagina is open, everything is go well, baby can go through, so your menstruation will go smoothly later on. So if you have a dysmenorrhea, sometimes we will recommend you find a husband, get a baby as soon as possible. Then you will have a better quality of life. Okay. Then let me see any question. Okay. This is your teacher and the role of the prenatal period. Male. Okay. Yeah. Okay. Okay. Any questions so far? There's another new message here.
Yeah, maybe you would like to ask to Prof. Yeah.
Any question?
ganti dengan.
If no question, let's go ahead. We have two more topics left. Okay, here is so-called infertility. In the United States, Taiwan, I think Indonesia, your country, have a different percentage because the United States do more research, so they have more data. If you are young, you got married between 30 to 34, 1 in 7 couple have got the infertility. It's not easy to get a baby. If you are get older, 40 to 44, 1/4 of the couple, 1 in 4 is difficulty to get a baby. Also, once you get older and older, maybe you go do the PhD training, or you are working hard to do the business, then you get married near 40, then you have a problem of infertility. You got money, but you're not easy to get a baby. So we have a technology to help these people. So these are fertility facts. If you unprotected sex for 1 year, no pregnant, then we call infertility. Generally, 1 out of 6 in the United States. And we cannot brand the female because the female only take 1/3, male take another 1/3, and both is 20%. We have a 10%. We cannot find the etiology. We cannot find the reason why there's an infertility. So we cannot brand our female partner. In the United States, you can see here. Okay, but 85% we can treat successfully by ART. The majority is like the male sperm count and the sperm defect. Some is a male have erection or ejaculation difficulty or deficiency. The female is a ovulation disease. Some is a fallopian tube occlusion. Some uterus have a blockage, and the cervical have a stenosis or precancer lesion. Maybe they have a endometriosis. Also, we have an intrinsic etiology, extrinsic and environmental issue. So we need to do the survey, like maybe we have an ovarian tumor, so we can do the ultrasound exam. Maybe have a polycystic ovary, because they cannot produce mature ova, and they impair the so-called ovulation failure of polycystic ovarian PCOD. We check the hormone, there's a high androgen level, and some is pelvic inflammation disease or inflammation, and then the transport of the gamete is a difficulty, have a blockage of the fallopian tube. So the doctor will do all the survey to find the etiology and to overcome the problem. And the male, like crypto or chitism, the testes is hide somewhere. Some is a chromosome disorder. Some is a vast difference, the obstruction of the transportation of the sperm. Some is a hormone deficiency, gonadotropin deficiency. So the final result is low sperm count, and the sperm, the poor quality, the migration, the motility is low. So we will do some tests, like basal body temperature test. You can monitor your temperature. Do you have an elevation of your body temperature? And then we will test the ovulation kit to test you have a LH surge. we can check your blood for different kind of the hormone and FSH, E2, LH, and progesterone, all the panel. And then we can do the laparoscopic exam to see have any inflammation, adhesion. We can do the histosalpingogram, use the dye and X-ray to see the patency, the pattern of the bilateral fallopian tube. We can check your cervical mucus is the acidic or they have some inflammation. Some people have a sperm antibody, or they produce antibody to against his own sperm. And we can do the endometrial biopsy to see is any polyp or hyperplasia and the difficulty for the implantation. Okay, so this is the body temperature. You take a record every day, you can see the change of your body temperature. And we can do the minimal invasive surgery laparoscopic exam, use the video to look at the inside to release the fallopian tube adhesion and to overcome the structural abnormality. This is the histosalpingogram, HSG, histosalpingogram. We inject the dye from the cervix to the uterus, and you can see the small lining, small thin. This is a pattern of the two tube, and the black tube is here. This is swelling, so right tube is black. And this is the left tube, the fibula end is black. If you is pattern, they will have dye open up in the abdominal cavity. The male, we can collect the sperm, the ejaculation for the laboratory test. So per male, we have at least 20 million of sperm. And we check the motility and the morphology. The normal is above 50% is motile, and the 30% is the structurally normal. So you know the standard is easy to meet because we have so many sperm. And then to check the LH androgen level, and sometimes if it's not good, we can do the testicular biopsy to see any sperm formation there. This is a sperm count. Okay, you can see this is sperm, this tail, how many sperm over there, and how's the motility. So this is the microscope, and we have a monitor to see the sperm, the digital image. Right now, we can do the AI analysis. There's an low and a low-tech treatment. We can use some drug. We can use intrauterine insemination. We can do the tubal surgery. This is old. Right now, we have a high-tech assist reproductive, so-called ART, high-tech, like IVF, in vitro fertilization and embryo transfer, so-called IVF and the ET, embryo transfer, and the GIFT, gamete intrafallopian tube transfer. We put the ovum and the sperm, the gamete, in the intrafallopian by surgery. Then they can fertilize by themselves and migrate to the endometrium. Or ZIFT, zygote. Zygote is fertilized and fertilize the egg, the intrafallopian tube transfer. The other is the most expensive one is ICSI, intracytoplasmic sperm injection, so-called ICSI, ICSI. I have a photo here. There's a history on the reproduction technology history. A couple almost 25 or 26 years ago, the sheep cloned. The sheep cloned. The first IVF baby, the Louis Brown, very famous one. And ART, every year in the United States have 40,000 cases, very expensive, so-called IVF-ET. This is gold standard here. The basic step is we need to stimulate ovarian stimulation by medication, by injection some drug. Then we use a sonography to egg retrieval, stimulate, and then the matured egg we can retrieve. Then we got a sperm and wash the sperm from the husband. They put into the culture, egg and sperm put together. They can fertilize. Sometimes we can get 10 ova in one time, and so many sperm. We can collect so many fertilize, and we find a good one. Do the embryo transfer to find a good one. Sometimes we can do the so-called PGD, pre-implantation genetic diagnosis, or we can biopsy the embryo to get rid of the genetic disease. If this is healthy, we can put into the endometrium, the embryo transfer, and we supplement the progesterone. Then the embryo will become healthy and to growth. So we start with more than one egg. There are so many drugs we can use. Oral is Formifen, and the injection is like HMG, FSH, GnRH, or Lupron. And like HSG, you can like LH. We inject HSG like LH surge, then got ovulation. So we transfer more than one embryo, we can increase the pregnancy rate, but also they increase the risk of the multiple pregnancy. So right now in Taiwan, we routine inject two embryo. Okay. So this is a singleton baby, a twin baby, a triplet baby. If you have a triplet, the mother will be very tired because you can think if one baby is 3,000 kilograms, 3,000 grams. If you have 3 babies, the tummy is very suffer. The mother will be suffer. Or then we go back to this toxic here. We try to mimic the normal phenomena. We collect the mature ova and maintain the endometrium. Then we can implant into the embryo transfer that got implantation here. This is use sonography. We do the transvagina through the vagina and then do the puncture of ovary can get an ova. See, this is the procedure, and then we stimulate the ova and get it fertilized, and then we can do the transfer, use a tube to help the implantation. So this is so-called IVF. The Taiwan IVF is very famous. So many people from Hong Kong, Taiwan, and China come to Taiwan for IVF because it's relatively cheap compared to Japan, Korea, and the United States. Taiwan is a little bit cheap. Okay, so there's a different kind of tubal transfer. But this kind we need to do the surgery, or put a tube into the fallopian tube, and put the egg and sperm here. They can spontaneously fertilize and then they go spontaneous implantation. But this tube, we need to do the laparoscopic surgery. So this is not very famous right now because the patient need to have two surgery, retrieve the egg, one surgery, and transfer the egg and sperm is another surgery. So right now, almost we do not see frequently here. We do the embryo transfer. If you can have a good laboratory, then you can close and let the sperm and the egg together. You can find which one is good and zygous. So we need to have a good laboratory technique. Okay, this is another technique, gift baby. And the zip baby. Also, we need to do the surgery. This is a zip. So this is easy. Easy is the most expensive one. You can use this one to hold the ova. This is mature the ova. And this is the needle, the glass needle. They collect one sperm, put into here, then use this one, inject into the ova, inject the sperm into the ova. So you help the sperm penetrate the ova. Then the fertilized egg have two nuclei, one from father, one from mother. This is fertilized egg. Okay. So there's some issue like surrogacy, cloning, human cloning, frozen egg, frozen embryo, egg donor. Not only medication, medicine have some law issue, social issue. Okay, so in the United States, majority, almost 70% by IVF ET. Give baby, zip baby, frozen donor. There's less. Some frozen from the patient cell, some is from donor, but majority is the IVF ET. Okay, so we almost finished. I have a final part is the contraception. Okay, contraception. Contraception. Here. Contraception is very important because if you do not need a baby right now, you try to avoid to get pregnancy. I borrowed a slide from Dr. Idris from Geneva. There's an outline. There's some method. Permanent method is a male. You can vasectomy. You can ligate or remove the vas deferens. The female is by tubal ligation. Once you have a baby, you can have a request your doctor to do the tubal ligation. Some is emergency contraception, so-called postcoital contraception. We have one night very happy, then we regret, or this is a danger period. So you can go to find a emergency contraceptive pill, so-called ECP. The other one is the copper bearing IUD, insertion IUD immediately. There's a traditional one is the LAM, lactational amenorrhea method. Once you have lactate, breastfeeding your baby, then it's not easy to get over it. Is keep the amenorrhea status. The other one is for the relation wellness method. Okay, right now not only the card, some have an APP. Once you have a cell phone, you can use the APP to awareness to remind you when is the dangerous period. The The other one is very old traditional method is withdraw during the intercourse. Before the ejaculation, we withdraw. Also, there's many methods to the family planning. Some is very effective, like the implant, IUD, vasectomy, sterilization. Some is less effective, use the condom, withdraw, spermicide. This can kill the sperm. Some is condom, diaphragm, awareness method, LAM, pill, oral pill, use a patch, vaginal ring, or some injectable medication. Okay, so many methods. No one method is perfect. Some is permanent, and some is very easy but less effective. Male sterilization. Okay, male sterilization. Just cut here. The doctor can find a tube here, and the blood like get here, sperm have no chance go to the penis. Okay, they have some complication. They have pain. Some surgery have fever, and some patient will regret. Some patient have a surgery, have abscess formation, inflammation, granuloma, anti-sperm antibody. And we have some physiological change. Ejaculation, erection not effective, sex drive not effective. Long term is fine, but the serum, the anti-sperm antibody will rise. So it's not easy to get once you do reverse surgery, but sometimes the antibody will keep going. Then the vasectomy, they depend on the male. If they will not remarry or do not want to have you can do the vasectomy. The timing, okay. Discuss with your wife and discuss with your doctor. Okay, there's a vasectomy. Then the female sterilization, female. We can see here, we can see the fallopian tube. We do the surgery to block the tube. And if you regret, the doctor can reverse to repair the block. The technique is fine, it's okay. But so we can do laparotomy, we can do transcervical. We can, majority is do the laparoscopic surgery. If there's a postpartum, or if you have a baby, then you can do a different kind of approach. So ask your doctor how to do the surgery safely. Okay, then the other one is emergency contraception, or use a pill, or use a copper T. IUD. So why is emergent? Because you only have 24 hours, 48 hours. If you do not do it immediately, then the efficacy is not good. You still have a chance to get a baby. So use the pill, or you can buy sometimes it's an import drug. Okay. The mechanism is to block your pituitary gland to the drug do not inhibit the implantation. So ECP do not cause abortion. If you already have a pregnancy, too late, they will not cause abortion. So the mechanism of action, because the ECP can affect here. They can work before fertilization. They will influence the ovulation. Okay. The effectiveness is fine. I think it's good enough. And right now we already have a abortion pill. So if ECP failure, we have some method to overcome. The safety of ECP is good. But I will become, right now we have COVID-19. If you do the AZ vaccine, ACP is a hormone. It's easy to get a coagulopathy, defense thrombosis. So if you do the other like the Medina or BNT vaccine will be fine. But you use the ECP, avoid the AZ vaccine. Okay, there's a ECP regimen. They have a progesterone, or they have a combined estrogen and progesterone, or progesterone only pill. There's a different combination, different company, different medication. Okay, so the timing up to 5 days after unprotected sex, but I will recommend you as soon as possible. Okay, the side effect, because they are high dose hormone, so nausea, fatigue, headache, breast tenderness, sometimes have a vomiting. This is so-called side effect. Because you have one happy hour, then you need to suffer several days of the side effect. Okay, I see. Then we have a so-called IUD, intrauterine device. There's a contain medication, levonorgestrel. They can last for 5 years. A very powerful IUD. The copper bearing IUD is but sometimes easy to get infected. So pelvic inflammation disease. So this IUD, emergency contraceptive, the timing should be inserted within 5 days of unprotected intercourse. I recommend as soon as possible. So emergency contraceptive do not interrupt established pregnancy. It does not harm developing embryo and embryo baby. So there's not abortion, the contraception is not the artificial abortion or sperm. So there's a different issue. The safety is high, and safety is good, but sometimes we'll get the pelvic inflammation disease, less than 2 per 1,000 users. Okay, so get a summary. The other one is LAM, lactational amenorrhea method. Because once you have a breastfeeding, it can effective up to 6 months after childbirth. Monthly feeding, there's fully breastfeeding, that you will not easy to get pregnancy. Because why? Because once the baby have a breastfeeding, we have a feedback go to the hypothalamus. The GnRH will low. The anterior pituitary gland will have a low LH and the FSH. So if your ovary have a low estrogen, then it's not easy to get a mature ova. So this cycle make you have a contraception. No egg, no pregnancy. This is the so hypothalamus, pituitary gland, and ovary. Okay, so the 3 criteria: a baby is less than 6 months old, and the baby need to full breastfeeding, day and night breastfeeding, and the menstruation never come back. So this is LAM. Very nature and no side effect. Okay. Okay. So the advantage, safe, nature, no side effect. Okay. Then I think I will let the slide to your teacher, and you can share the slide. Too many information here, but the key point is that right now we go through all the issue. Okay, any question?
Yes, thank you, Prof. I think Dia has question. Please, you may ask to Prof. JT. Dia, please.
Yes, ma'am.
Is the success of IVF program low? Okay, it is a very good question. I heard the people who do this often fail. So far is the factor that causing this. Okay, right now, let's have a rate. Let me find a. Okay, maybe I missed. Oh, here, the next slide. Sorry about that. And do you see this slide?
Not yet, Prof. Still the previous slide, Prof.
Okay, let me find one. Here. IVF success rate. Okay, we the average, the pregnancy rate around 1/4, 25%. Take-home baby rate is around 20%. If you have a 100 cycle and you got wonderful ovarian stimulation, 95%. 90% you can get a mature oocyte. 85% got the fertilized egg. 70% we can do the embryo transfer. So you can see this is in the laboratory. Laboratory, we can do 70% successful rate. But what happened? Embryo transfer, then gut pregnancy only 24% or 25%. You know what's going on? Because the embryo is not successfully implanted. This is so-called endometrial recessibility. So if we can do the research over here, we can make the success rate go up. Because once you have a pregnancy, but sometimes pregnancy will have a spontaneous abortion, or sometimes the baby is not normal, and maybe you have a complication of placenta previa, twin pregnancy, then the baby died in intrauterine, so-called IUFD. So-called and the take-home baby rate is around 20%. So the student asks the right question. Yeah, the successful rate is low, but so we need to average. We need to try 4 to 5 times to get one baby. And if you are young, around 30 years old, maybe you try 3 times to get one baby. You are 40 or 45 years old, you maybe try 6 times or 7 times to get one baby. Then the doctor will try to get a twin pregnancy for you. Maybe you one delivery have a twin, and you got 2 babies in the same time. This is right now the phenomenon. Okay, any question? Any question?
Prof, may I ask question, Prof?
Sedangkan di LKPD Uniform 2 itu hanya menjelaskan terkait dengan
Wayang. Yeah, where is that from, Prof? Where's
This is a gift from your student from your country.
Oh, from UGM.
Nah, discovery learning-nya belum muncul. Nah, kalau menurut saya meskipun sebenarnya di sini
yes, puppet. Leather puppet.
sebagian lebih diimprove lagi sebenarnya meskipun memang sudah masuk digital learning ya, tapi mungkin saya yakin kalau beliau bisa lebih dari KPD
If you are interested, you can look at our
digitalisasi.
website.
Yes, Prof. I have also informed the student. Prof, maybe one question, Prof. How about sexual orientation, Prof? Do reproductive system has part in determining sexual orientation? For example, I was born to be a woman, but I act like a man, like that. Yes, Prof.
This is a very important and very tough question. We have a so-called genetic gender, like I genetically SY is the male. Then some is the so-called phenotype gender. Genetic is become our gene, but some gene is not work well. Some you have a gene, but gene is defect. So you have not mature, so you become genetically maybe you are XY, but your appearance is like a female, like a girl. This is a genetic defect, a hormone receptor, something like that, the defect. And this kind of patient, we can use a hormone to modify. They can become the a little bit normal. We cannot say normal, depending on their desire. So the doctor will ask the patient, you want to keep your baby, you want to be a male or you want to be a female. Another one is a so-called social issue. Some is look like the genetic is male. The phenotype, they look like male, but he want to become a female. So this is they have a so-called transgender. Transgender. This is a very popular issue, and all the scientists want to study what's going on, but right now still no answer. But we do see some people, the chromosome is XY. He look like a male, look like a boy, but he want to become a girl. He want to become a female. They're very interesting. He want to get rid of his penis. He want to remove his scrotum. Yeah, but we don't know why. But in the medicine, we need to do the more research to under what's going on. So this is a very wonderful question, very good question.
So is it a disease or maybe sins, Prof?
Right now, the medicine area, I've been a doctor, but majority of like the United States, they put this patient as a disease. But some countries do not see this as a disease. This is maybe education, maybe from influence from his classmate, from his colleague, or from his environment. But we need to do the research to figure out what's going on. I see different countries have a different percentage. Different countries have a different approach. But being a doctor, I want to make sure this patient, this guy, try to get the help from doctor. We want to know more what's going on, what's your development, what's your family, what's your relationship with your family. Yeah, I think that's very important, but it's a very tough issue. Okay.
Yes. Thank you very much for the answer, Prof. Okay. Any other question, class? Any other question? Yes, Elizabeth? No? And we?
Okay.
Mm-hmm.
Okay, I enjoy the lecture today, but I very much apologize because I'm very busy in the hospital, so I do not have time to put the 5 slides in one PowerPoint. So yeah,
Yeah, thank you very much for your valuable time, Prof. But maybe before we end the session, I will ask students to open the camera to have a photo session.
Yeah.
Okay, please open your camera, class. Okay, okay, Dia, you can start to have the photo. The other who hasn't opened the camera, please open your camera. Actually, one more question, Prof. Do you believe on, do you believe on vomeronasal organ in human, which also act like the thing they have in animal for sexual attractants like that, Prof? Are there any vomeronasal organ in human? So we smell some male, for example, and then we feel the attract the feel of attraction to some
Yeah.
person.
Right.
Mhm.
So-called like a perfume. The female use perfume to attract the male, and the male they have a so-called in the animal we call pheromone. Pheromone. Yeah. See the smell. Sometimes you can look this very attractive you, and somebody very handsome. But you know, this different standard, different culture. In the maybe some people maybe you are looking very choppy, very attractive. Right now, the gold standard comes from the Western country. You look very thin, it's very attractive. Depends, you know.
Yes. Okay, so many factors involved here, Prof.
Yeah, right, right.
Okay. Mhm. Yes. Okay. Dia have you take the picture? Dia?
Yeah, I
Yes.
will take the picture. They are one slide and I will take 3, 2, 1. Okay.
Okay. Okay. Thank you very much again, Prof, for your valuable time and also knowledge. It's very happy you're in our class. Hopefully, we can meet you in Korea, or maybe we can invite you here to Indonesia. Okay. See you again, Prof.
See you.
Thank you,
See you.
Prof.
Good evening.
Take care,
Assalamualaikum.
everybody.
Okay, class.
Bye.
Thank you. Bye.
Bye.
Thank you, Prof.